Would you rather do steroid injections for your job all day, or would you be home doing telehealth?
Okay, now we can't manage your pain any further than we already have, so you're going to go to pain management. When that's not the case.
How do you balance a patient's condition, whether it's prescribing them like medication or like conservative approach? Like, how do you make that decision as a PA?
No, the diagnosis or the criteria for fibromyalgia is really hard to diagnose. Occurs a lot more in women. And so I think with that, there's also like a stigma about like treating those symptoms.
Welcome to the STAP podcast, where we talk about the pre-PA life, PA school, and the PA you always dreamed of. Today we're joined by Martha Carmella. She's a physician assistant specializing in pain medicine. Martha is a Bay Area native from San Francisco, California, and a proud graduate of Cal State Monterey Bay PA program. With a background in athletic training, sports medicine, and physical therapy, Martha brings a unique perspective to pain management. After spending a year in plastic surgery, she's dedicated the past 3.5 years to helping patients manage their pain at her clinics in Brentwood and Stockton. So without further ado, here's my full conversation with Martha. I hope you enjoyed this conversation. How would you describe your role to others working in pain medicine?
All right. So I would describe my role as pretty I would say pretty autonomous. Like I have a lot of autonomy in working in pain medicine, and it can be very sometimes it can be very, I would say, like difficult dealing, only because pain is so subjective, right? Like it's not a vital sign that you can typically
Mm-hmm.
measure. And so it's like it depends on the patient, it depends on their mood, it depends on what we're treating. And so sometimes it can be difficult, but then other days it can be very easy, or I wouldn't say easy, but more mundane, to where it's more like repetition. So, to a student who's kind of looking for, if you like a lot of patient education, some procedures, you get a little mix, that pain medicine might be for you. But if you're looking for something that's like new every day, challenging in ways more like emergency medicine, then I'll probably say go that route. But yeah, like for me, I think my role is important, and it's, as any PA role, right, is crucial, because patients come to me and they're in pain, they have chronic pain, right? So it's like really leaning in and understanding your patient, right? So just being very receptive to different personalities. And so it's more so based on like personality and not necessarily their condition, but like how the patient is feeling that day. And so it can be complex, but at the same time, it's very rewarding. I guess I could
Okay.
say that.
What do people get wrong about pain medicine? Because when I first heard about pain medicine, I was like, I'm definitely not going to do this because sounds like who would want to go into people coming in pain all the time? And I had actually my second rotation in neurosurgery.
Mhm.
So I dealt quite a bit with people coming in for pain. And then if they had surgeries, like if the pain wasn't going away, like we would have to refer them to pain medicine. So, what do people get wrong, in your opinion, about pain medicine from a perspective of PA and PA students?
Yeah, I think that's a good question. I think two things come to my mind. One, we always have the stigma of pain medicine is just prescribing opioids. And so that is not the case, right? In
Hmm.
fact, we're actually moving away from that. And so working in pain medicine for 3.5 years, I can say that that was what I thought initially when I took this job. Like what else could I really be doing besides prescribing oxycodone, Norco, whatever? But it's actually a lot more to it. And also the second thing that I think about is it's kind of like the end of the rope for patients that have had surgeries, and it's like, okay, now we can't manage your pain any further than we already have, so you're going to go to pain management. When that's not the case. Most of the time we get, acute pain that we actually work in collaboration with other specialists to treat their pain, as opposed to being the last resort. So that was a couple of things that, thinking when you first think of pain medicine, I'm pretty sure that generally that's what people think. But yeah, working in pain medicine has been very rewarding because I'm able to like see this whole process when helping patients. And it's not just chronic pain. Sometimes it's acute pain from an injury sustained and they can't really, like we're managing it concomitantly with something else. And other times it's just solely like their chronic pain from, overuse or like chronic injuries, osteoarthritis or something like that. And so it's not just about prescribing medication, right? So we actually work in collaboration with a ton of specialists to help manage patients' pain collectively, right? So you mentioned neurosurgery. I refer my patients to to neurology, to orthopedics, to and we could even talk about from a conservative standpoint first before we even get to referring to specialists. So like physical therapy, we're utilizing acupuncture, chiropractic care, aquatherapy, in addition to managing their pain with medications and other neuropathic pain medications.
How do you balance a patient's condition, whether it's prescribing them like medication or like conservative approach? Like, how do you make that decision as a PA?
I think it comes with experience and depending on the patient, their
Hmm.
condition, also like
Yeah.
what meeting the patient where they are and what their expectation is of managing their pain.
Hmm.
Sometimes they feel like we're not managing their pain adequately because we're not giving them a certain prescription or a certain medication that they want, right? So it's just really about patient education and helping them understand like, here, I'm trying to help you utilize all aspects of pain medicine to give you the best outcome, right? To be more functional and helping patients understand that it's not necessarily helping them be pain free, right? Because that may not be the case with a lot of chronic conditions, but we can help them get as close as possible to being functional. So that may look different from patient to patient, right? One patient may be managed well and is able to reach a functional level just with gabapentin and some ibuprofen and a little physical therapy. And on the flip side, another patient that would not work for, right? So it depends on the condition, but also their mindset and like what they want to achieve. Yes, like I want to be more functional. I want to get back to like working out or like walking with my grandkids without pain. It's like, okay, so now we have to have a different approach, right? That may look like some injections and some PT on top of conservative therapy, lifestyle changes that they can manage on their own too. So a lot of different approaches.
Yeah, so let's say we talk about like maybe three worst conditions you see, whether it's in the realm of like neuromuscular disorders or other disorders. So what are some three worst conditions you see in your practice?
Top three worst.
Or
Well,
just
definitely,
one?
yeah, like I would say any like disc injury or spinal
Hmm.
cord injury is obviously going to be the worst, especially if their mobilization or if they're, compromised in that way. But
Hmm.
yeah, we get a lot of like chronic herniated discs or facet joint pain. So it's
Yeah.
like more arthritic changes in the spine that you can't really change structurally, right? You can't really do
Hmm.
much about it. So those are hard to kind of manage because structurally they don't want surgery. There's no like fusion or anything that's warranted at that time, but at the same time, it's like movement hurts. So how do you like approach that? So I would say mostly in the lumbar, get it a lot in the cervical too. Second, I would say any like neurological deficit, because with that comes like motor compromise, weakness, decrease in function. So that could be, something like CRPS, right? Chronic regional pain syndrome is really, really hard to treat because it doesn't always present physically, but then the patient will have symptoms of like, paresthesia, numbness, tingling, burning in a limb, cold sensation, but their hand may or limb may look normal, but they're like telling you that this is what they're feeling. So those can be pretty tricky to treat. And then last, maybe I'll say like a fibromyalgia or something like that. It's
Oh
very
yeah.
vague.
Yeah.
Yeah, symptoms that like total body all over pain, inflammation. And we're like, okay, like, can you give me like what area? And they're just like everywhere, right? So if you know the diagnosis or the criteria for fibromyalgia is really hard to
Mhm.
diagnose. Occurs a lot more in women. And so I think with that, there's also like a stigma about like treating those symptoms. So yeah, I would say those are my top three, along with the like knee osteoarthritis and all that stuff.
Yeah.
Yeah.
for your disc injuries and your spinal cord disorders, what are some of the things like we as future PAs may miss, or some of the things that we should work on in order to treat patients effectively if we have the opportunity to be in your position someday?
You're
Yeah.
looking at
Yeah, what are some let's I can reframe it in terms of like, what are some I have heard a lot about listening skills recently. Like every PA I talk to, they have said listening skills are really important
Mhm.
for, patient quality or patient outcomes and everything about. But I'm looking for more of like, what are some skills that we as PA students should develop for treating and managing spinal cord disorders if we have the opportunity to be in your role in pain medicine?
Yeah, okay. So I wouldn't even take it as far as like spinal cord disorders. I would just say in this specialty in general, as a
Yeah.
student coming in with an open mind as far as like what pain looks like for each individual, right? Because I think we have our own biases,
Hmm.
right? And coming into a new role as a PA from being a student, you kind of have, our set biases, seeing patients like, oh, this patient doesn't look like they're in that much pain, right? Or like we judge based on what the patient is telling us or what they look like, or if they're overweight, then you're like assuming that they're lazy and then that's why they're having pain because they're overweight. And although that's just an example, but although that may be a factor, like we can't really use that as a reason to treat them a certain way. And so we're all guilty of having our biases, right? So as a student coming in, I think it's important not to just look at the condition and say like, oh, this is what I would do, but like really look at the patient as a whole. And I think that's with any specialty, wherever
Hmm.
you go, right? It's like treating the patient as a whole and looking at them from a perspective of like learning, meeting, like I said in the beginning, meeting them where they are and asking them like what their expectation is. So they come in, I'm like, what do you want to get out of this visit? And they're like, I want to be pain free. And I'm just like, okay, let's stop there because one, that may not happen for you. So I'm just setting up so the expectation that they're not going, just being realistic about their treatment and their pain. So one, setting the precedence there and then moving forward and with realistic expectations and treatment options that they can understand, but they also know and feel that I'm listening so that, they're like, okay, she is hearing what I'm saying and listening to how I'm feeling. And we're meeting halfway so that one, they feel like they're getting the appropriate treatment and I feel like I'm treating them adequately. So that's huge. I think just removing our biases in general, especially in pain medicine. Because, like I said, the stigma of just when patients come in, sometimes you just assume that they're there for medication, and that may not always be the case.
Yeah, it looks like in pain medicine, you have to start from the basics and not jump to conclusions early on in order to treat patients.
Yeah.
Yeah.
Yeah. And yeah, it's important. It's the listening factor. There's a lot of that. So being a good
Mhm.
listener while you're going through like your clinical rotations and like you're getting opportunities to meet different patients with different conditions, listening to their needs, but also being realistic about their treatment options, I think is pretty key.
How do you talk to patients about managing their pain expectations and their biases? Like maybe they just think that, oh, going to pain management or pain medicine is just receiving medicine. So how do you like approach those conversations?
I'm just honest with patients.
Hmm.
Like, and I'll let them talk first because I don't want to come in and assuming anything. So, I'll come into the visit, like, just kind of like talk about something else other than getting straight to it, right? To let their guard down a little bit. Because every time you come in, it's like, you got to understand when patients are in chronic pain or when they're in pain in general, like, there is sometimes a wall just put up right away or just like apprehension. And they're just like, I'm just here attitude, I empathize. I'm like, of course, I understand who's going to be like walking around chipper and happy when you're like in pain. Like, I totally get that. So, coming into the visit already, just letting them kind of vent and tell me like what they're feeling and assess, read the room, so to speak. And so then I can go from there. If I know that they're more like chill, like, I'm just here. A lot of them are work comp injuries, right? They're like, I'm just in a lot of pain. I just want to be treated right. I just want to figure out what to do. And I'm like, okay, so we got a foundation. Other times I'll have a patient come in and they're just like, I'm just here to get some pain medication. And I'm just like, okay, let's back up a little bit. Like, my name is Martha. Nice to meet you. So I kind of just like redirect, so that they're not really kind of taking control of the visit, right? So, like, you kind of have to reel them back in and kind of settle down a little bit for them to like open up and listen. But I do have those patients that just come in and just expect some opioids. And I'm like, that's not what we do here. So if that's your expectation, then I can maybe refer you to someone else. But if you're willing to listen to, some options, like I'm pretty sure I can help you, but you got to be willing to be open to other treatments. And they're
Okay.
usually okay with it.
I would like to switch gears in asking you what are some of the procedures that you do, or what are some of the hands-on things that you do, and maybe just your schedule on a day-to-day basis. I know you're working from home today, so I would love to know like your schedule, typical schedule in a week, and what kind of stuff that you do from day-to-day life.
Yeah, I absolutely love my schedule, and that's one of the reasons why I'm also in pain medicine or the practice that I'm at now. I am off on Monday, so I only work Tuesday, Wednesday, Thursday, Friday. And Tuesday, Wednesday, Friday, I'm in clinic, and Thursdays I work from home. So essentially 3 days in clinic, which is not bad. But when
Wow.
I am there, when I am in clinic, I see about 25 to 28 patients a day, which is a lot,
Yeah.
right?
Okay.
But I feel like it's doable because I'm not there 5 days a week. And I honestly feel like I would be burnt out if I saw that many patients a week, like every day. So it's a good balance. Thursdays is usually on the lighter end, so I can manage, from the earlier days in the week, from it being so hectic, I have time to like catch up on charting, and I could do that from home too, so I don't necessarily have to be in clinic. So yeah, on a in clinic, I work in two different offices. One is about 10 minutes from my house, and the other one is about a 50-minute commute. So it's not bad on a day to day. So yeah, about 25 to 20, 28 patients a day, sometimes 30 at the max every 15 minutes. I'll have some majority follow-ups. So I'll see patients for follow-ups for medication refills, if they had procedures done. So my supervising physician does all of our like epidural steroid injections, our nerve medial branch blocks, and nerve ablations of the spine. Those are all done at our surgery center. And so I'll see follow ups from that. So once they have their procedures, they come to me, kind of let me know like how the procedure went, like what they're feeling, if they got pain relief, if we did like the lumbar injection and we need to do SI joint or left versus right or bilateral. So we'll figure all that out. And then on top of that, I do injections in office. So I'll do like joint injections, shoulder, knees, hips. So bursal injections, cortisone injections of the knee, subacromial injections in the shoulder, TPIs. So trigger point injections, paraspinal muscles from the cervical all the way down
Mhm.
to the lumbar.
So it sounds like a lot of neuro and orthopedics.
A lot. I mean,
I love
my
it.
background, yeah, my background was in ortho. So in sports medicine, I was an athletic trainer before I started PA school. So it kind of like overlapped, which I feel like was a huge bonus for me because coming into this, you have to have like a good foundation of anatomy and orthopedics, orthopedic related injuries, know your anatomy for injections and stuff. Cause I don't use ultrasound guided, but we could if I had to, but I usually don't. Yeah. And so a lot of neuro too. Got to know your like dermatomes, myotomes. So just with when patients present certain, neurological issues, you kind of have to map it out and know like what level we're injecting, right? So if a patient's like, oh, I'm having, radicular pain and down into my big toe, that's L5, or I'm sorry, I'm a lateral side S1, so you kind of just figure it out. Unless you need, you always get imaging if you need to, MRI, CTs.
Yeah, so for the longest time, I've been trying to figure out if there's a crossover between cardiology and ortho because I think I love those two. But I haven't, the only thing I've found is sports cardiology, which is like young people, so like peds, but also
Yeah.
like peds, but also they're athletes. So it's not like true orthopedics.
Yeah, and then you'll probably get more like the Marfans and stuff like
Yeah.
that, like for those type of athletes. Not necessarily a lot of orthopedic crossover for that. Definitely in pain though. Definitely.
Yeah. So I do definitely like this too, because I never thought about this, that pain medicine could be, neuro and ortho. I'm relatively new to this specialty, like learning about this specialty. So
Mm-hmm.
that also opens a lot of doors for me potentially, because I love my undergrad was in neuroscience. So what
Okay.
was your
Yeah.
background before this job, or was this your first role out of PA school?
So my background was in sports medicine. I was an athletic trainer, so I like rehabbed athletes like when they got injured. I
Okay.
worked with at a D1 Division 1 college at University of San Francisco. So I worked with their women's soccer, basketball, track and field, baseball. So I got the gamut of like the athletes and their injuries.
Mhm.
And that kind of sparked my interest because I had an athlete like sustain a really bad injury, like an open tibial fracture. And so that led me to want to become a PA, and I really thought that I wanted to be an ortho. Like I'm gonna do orthopedic surgery. That's it. But
Why
then
did you
once
not?
you go through your rotations and stuff, and then you kind of
Oh.
like learn what you like, what you don't like. Like I knew I didn't want to do emergency medicine. I didn't want to do internal medicine, although they were cool as rotations. So this was like a sweet spot because I was like, yes, I still get like my little orthopedic, like, I get that when I need it. And then also just a combination. You see a lot of other stuff too, because a lot of my patients can be like diabetic, right? And so we have to consider that with like cortisone injections, or
Mhm.
if they're obese, like I'm trying to prescribe like a GLP-1 or something to help them lose weight so that they can have surgery, or, just helping to kind of get that process going for them. So you're in a lot of different like subspecialties within pain medicine. You'll see a presentation of a lot of different conditions, right? I have a lot of patients that are being followed by cardiologists. They're on blood thinners, right? And so we got to manage that because if we're doing procedures, we got to like be careful with, if they're on Eliquis or something like that. You get a lot of like internal med overlap, ortho, neuro, even OB-GYN a little bit, just dealing with like my female patients with chronic pelvic pain or something like that. There's a lot of other subspecialties that will present themselves in pain medicine, which I think is pretty similar to like primary care, right? Like I feel like that's the only other
Yeah.
specialty where you're going to see an array of like everything and then you just have to treat accordingly. But unlike primary care, right, where you're referring or treating and they're referring, we're pretty much referring if it's like out of the pain medicine scope.
So why not ortho?
I think maybe I just didn't really care for my ortho rotation. Even though I really loved orthopedics, like I think it kind of rubbed me the wrong way where it was. And so I didn't get the best experience as a student.
I get
I
that.
guess now, yeah, now for me looking at ortho jobs, they're very demanding. A lot of my decision for this job was based on like my lifestyle and
Mhm.
my family. Like I have 3 kids. At the time I had two. And so just wanting that flexibility was like huge for me. And I don't think orthopedics really would allow me to do that because one, you're in surgery, you're first assist in the OR, depending where you are, right? But that can be very demanding and sometimes you're not sure of your schedule. So I needed something that was like, I know what my schedule is going to be and I can be flexible if I need to. So that's what really attracted me to this job. The flexibility, the pay is really great. And, so it's like not too hard, and I'm
Yeah.
not like working super long hours. So it kind of depends on like, what you want to do, what your lifestyle encompasses for you to
So this was
decide.
your first role out of PA school.
No, it was not. My first job was in plastic surgery. It was totally random. I came
Okay.
out and I was because I was like sure I wanted to do ortho, right? But then when I came out of PA school, I was like, I don't know. I don't want to do ortho anymore. So what do I want to do? It's not that I didn't want to, but I was like, okay, didn't really like find a job that I wanted at the time. So I was
Mhm.
like, all right, don't want to go into any other specialties. And it kind of fell in my lap, the job. And so I just took a chance and I knew I liked surgery because I wanted to do some type of surgery and it was cool, but it was very demanding, right? So I think any surgical role that's full time is going to be demanding. And so I did it for almost a year, gained a lot of experience. My suturing skills are like top tier, right? It's plastics, right? You got to have that suturing down. But yeah, it was a point where I had to decide if I wanted to like spend more time with my kids or continue with this super demanding job. And so I chose family, and that's how I landed here. So this is my second job out of PA school.
Okay, last
Been here
question.
ever since. Yes.
Sorry.
I said I've been here. I did that. I did plastics for about a year, almost a year, and then left and started in pain medicine about a month later, if that. And then I've been here ever since.
Awesome. Yeah, I mean, and when I get to the end of this last 7 months that I have in school, I'm afraid that at the end I'll be like I wouldn't be sure. So I ask you this question because this might be my personal question too. Like if I really want to go into pain medicine, what I have to do right now in order to do that right after graduation?
I think it might be helpful to see if you can shadow a PA in pain medicine for one. I
Okay.
know that you're a student, right? So it's like you do
Mhm.
that before you get into PA school, but it wouldn't hurt just
Yeah.
to kind of get some insight and know for sure. So if you're interested, let me know. I'm in the Bay Area, so I'm not sure where you live.
That's too far away from me. I'm in
Where you live?
Savannah, Georgia.
Oh shoot, yeah. I know some PAs in Atlanta, and I'm down there. I was down there a few
But I
times and see.
appreciate it.
Yeah, or just like kind of look into like what type of pain medicine practice, like if it's more integrated and they do, like referrals to like, and work with a lot of specialists. You can feed your orthopedic itch by, getting in a practice like that and just kind of just when you're doing your job search, just being open about like what you're looking for. And they'll tell you like, oh, here, this is what we do. We don't only prescribe opioids, and but not every pain medicine practice is the same, right? So you got to kind of do your homework and figure out how you can integrate yourself in there.
Okay, awesome. So to end this, quickly three rapid fire questions for you. Does like this or that questions. My first question is if you were a PA student again, which you probably don't want that, but just for the
Never.
sake, yeah,
I've never wanted to go to PA school.
yeah, definitely. But if you were in PA school, if you're going through clinical rotations, let's say you had orthopedic surgery as your elective, but it was a good location, a very receptive location, you would do a lot of hands-on stuff versus a location that was in pain medicine, but it was a total disaster. They didn't let you do anything. How would you still stick to pain medicine or would you go to ortho? And if you had a good work life balance in school.
Yeah. I think you know the answer.
Okay.
I'll probably pick ortho because I cannot be in a job where I can't do anything. Like
Yeah.
you go to school for 2+ years to have the autonomy to make decisions, right? To think critically and to go into a job where your supervising physician doesn't let you do anything. To me, that tells me that like they don't trust me, right?
Mhm.
And I understand that you have to work up to that, but um I would have to pick ortho because I need that. I like to work independently, but also can work with a team. And I just love being hands on with my patients. So that's a non negotiable.
Fair. Second question is would you rather do a full body circuit training or would you do just a full body bodybuilding style training? What's
Full
your
body
favorite?
circuit. Full
Okay.
body circuit. Yeah. I like to get in and get out.
Yeah.
I mean,
Quick.
I feel like the heavy lifting at times it serves its purpose, but you got to be strategic about that
The
or else
time.
you'll be there forever.
Yeah.
We work out a lot.
I do work out a lot. I'm into like just powerlifting and
Okay.
well, I recently started powerlifting. I wasn't into powerlifting. Yeah. But I do like the idea of circuit training, but my heart is not yet built for it. I need to work up. Yeah.
Your heart meaning
Yeah,
physiologically or
like
mentally or both.
both.
Yeah.
Yeah. And then the last one, would you rather do steroid injections for your job all day or would you be home doing telehealth? It's this or that.
I'll probably be home doing telehealth with infections all day. Like, yeah, I'll be fine. I mean, it's cool, but if you're doing like the same joint, it's like maybe if there was a variation in there, I
Okay.
would. But I don't have to do that. I get a combination, so that's a good thing.
Okay. All right. Well, this was our episode, guys. Thanks for watching, and thanks, Martha, for joining us today and sharing all the bits and pieces and pearls you had to share today with us. So, but
Thank you. Yeah,
thank
and
you.
if you have any other questions, you can message me, DM
Awesome.
me.
Yeah.
Yeah, I hope you
Yeah.
got
People can find you on Fit and Fly PA. Is that the
the Fit and
username?
Fly PA. Yeah.
Oh yeah, that's a great username. But yeah, follow her on Instagram, and yeah, catch you in another episode. Thanks for watching.
Thank you. Appreciate it.